Okay, we are right at 10:30, so why don't we get started? Good morning, everyone. My name is Tom Clark, and I'm the director of SAMHSA's National Mental Health and Substance Use Policy Laboratory. Thank you all for joining us for this session on the health risks of marijuana use, state of the science. You'll be hearing from 4 presenters, including myself, for this session. I will begin the session with data on marijuana use and its effects, as well as discussing key policy issues in SAMHSA's response. Following me, you'll be hearing from Dr. Krista Weissall, from the Professor of Psychology from the University of Wisconsin-Milwaukee. She will be discussing the neurocognitive effects of cannabis on adolescents and young adults, as well as sharing information about adolescents' brain cognitive development study. She'll be followed by Dr. Ralph Hingston, Director of the Division of Epidemiology and Prevention Research at the National Institute on Alcohol Abuse and Alcoholism, who will share successful alcohol policies to consider when developing marijuana policy. We'll end the session with a discussion by Mr. Scott Gagnon, Director of the New England Prevention Technology Transfer Center and Associate Director of AdCare Educational Institute of Maine. He will specifically be talking about SAMHSA's Prevention Technology Transfer Center. Please feel free to ask questions throughout each of the discussions. We also will be leaving some time at the end of each presentation for you to ask some specific questions of each presenter. And at the very end of all 4 presentations, we will have 15 to 20 minutes for a more formal question and answer. Thank you, and let's begin. Next slide. Next slide. This is just a disclaimer and disclosure. So the views, thoughts, and opinions reflected in this presentation and those of this session, including any handouts or related materials, belong solely to the presenters and do not necessarily reflect the official views, policies, or position of the U.S. federal government, Department of Health and Human Services, SAMHSA, or CADCA. I have no financial or other potential conflicts of interest disclosures to make. Next slide. So in my presentation, there will be 3 parts. The first, I will talk about marijuana backgrounds and facts, where I will present a lot of the data in terms of what we know about marijuana use in the US. I then will talk more specifically about adverse health consequences associated with marijuana use, and specifically talking about risks associated with adolescent marijuana use, as well as marijuana use during pregnancy. And then finally, I'll talk about SAMHSA's response in terms of what activities we are doing in order to respond to concerns about marijuana use. Next slide. So this slide represents the most recent NISDA 2018 data that we have, where you can see a listing of various illicit drugs. And you can see that marijuana, we have the most significant prevalence of marijuana use in the US. And I should note that there has been a significant increase in the 2017 NISDA data and the 2018 by 15%. So marijuana is the most commonly used illicit drug in the US. And approximately 43.5 million Americans aged 12 and older report using marijuana in the past year. Again, this is our 2018 data. Our 2019 data is not available yet, but should be available soon. Other data sources that also have tracked marijuana use include Monitoring the Future, which many of you may be familiar with. Monitoring the Future tracks substance use among high school students, and in recent data that they've had, they also have seen a significant increase in marijuana use, particularly vaping. So it's important to note. If you actually are not on mute, if you could put yourself on mute, there seems to be a lot of background noise. That would be great. Thank you. Okay, next slide. So I wanted to drill down a little bit more in terms of the marijuana prevalence that you had seen in the previous slide. So if we look at marijuana use among specific populations, here we can see that 18 to 25-year-olds really are the age group where we're seeing the most significant increases. And between 2015 through 2018, there has been a fairly steady increase each year, although 2017 to 18, it has plateaued a little bit. So this is a population that we are very focused on at SAMHSA, as well as many other agencies, because there has been such a great increase, and also significant risk factors associated with marijuana use for adolescents, which I'll be talking later about. Next slide. The other population that we have been very focused on is marijuana use among women by pregnancy status. And so here we can see, again, 2015 to 2018 data, that among pregnant women, there has been a steady increase from 2015 to 2017. The good news is that in 2018, we had seen a significant drop, which is good. But among non-pregnant women, there has still been a fairly significant increase between 2015 and 2018. Next slide. So in terms of trying to explain some of these data and why we are seeing such a significant increase of marijuana use among those two populations I mentioned, but also more broadly when you look at prevalence data for marijuana compared to other drugs, certainly it's very important to think about the social environment in which we live. And currently, there have been significant changes in marijuana laws in many states. Currently, 33 states and DC have legal medical marijuana use, and 11 states and DC have legal recreational marijuana use. And then if you look at the map of the US, you can see that the dark shaded green represents recreation and medical use that is legal. The next shade of green is legal, but it's at low levels of TCH, which we'll talk more about. Medical only is the light green, and then no marijuana or cannabis use at all would be the gray. So very few states have, no cannabis access programs at all. So I think that's, the social environment, it has been changing and it's become more normative. There has, certainly you could say there is an association between that and the significant increases that we're seeing in marijuana use. Next slide, please. So there are several states that have ballot initiatives to legalize recreational marijuana use, and this is a listing of those states. There are currently 9 of them that are on the ballot for 2020. So those include Arizona, Montana, New Jersey, Ohio, South Dakota, Arkansas, Nebraska, North Carolina, and Oklahoma. And as many of you probably know, states have legalized marijuana for various reasons, but I certainly the tax incentives can be one motivating factor. Next slide. It's very important to note that marijuana today is very different than it was, decades ago. And one of the reasons that marijuana is so different is because of the potency of TCH. And the TCH is a component responsible for euphoria or intoxication. So the marijuana available today is much more potent, and there's been several studies listed here that show the significant increase in potency. So in a study in 2016, it was documented that the potency of marijuana had increased threefold from 4% to 12% between 1995 and 2014. Also, marijuana available in dispensaries, specifically in some states, has an average concentration of THC by 17.7 to 23.2%. And concentration products, those known as waxes or dabs, have even higher levels of concentration, and some research has shown 23.7% to 75.9% of THC. So certainly the potency of the product today is certainly a concern, and we'll talk more about that through the presentation. Okay, next slide, please. So exposure to higher concentrations of THC carries greater risk of negative consequences and may also mean greater risk for addiction. So marijuana use can lead to cannabis use disorder and addiction, and data suggests that nearly 10% of those with marijuana who use marijuana will become dependent upon it. Next slide. So now I'm going to move into the second part of the presentation, which is talking more specifically about some of the adverse health consequences associated with marijuana use. Next slide. So one area where we see adverse effects of marijuana use is around cognition. And so it has been documented in the peer-reviewed literature that marijuana use is associated with impaired short-term memory, difficulty with complex tasks, and difficulty with learning. In terms of executive function, adverse effects associated with impaired decision-making, increased risky behaviors, such as sexual behaviors, also concerns around mood, and being associated with anxiety and psychosis. Next slide, please. Looking more specifically among adverse effects for adolescents as the population, we have seen several studies that show that marijuana negatively impacts learning, and chronic use has been linked to declines in IQ, poor school performance, increased dropout rates that can jeopardize professional and social achievements and life satisfaction. MARE 2012 is a very widely cited study and very comprehensive that talks about several of these issues. Adolescent marijuana use is also associated with other substance use, and it also has been associated with prescription pain medication specifically. People who use marijuana in younger ages, so before 18 years specifically, are 4 to 7 times more likely to develop cannabis use disorder than adults. And so certainly in the developing brain, at younger ages, before 18, it is really important to think about how substance use can negatively impact that and how that has adverse consequences that in some cases could be long-term effects. Next slide. Marijuana use is also linked to earlier onset of psychosis in youth known to be at risk for psychotic illness. So certainly there's a mental health side of this. Exposure to marijuana in adolescence has been cited as being associated with increased risk for psychotic disorder in adulthood, higher rates of school suspension, and higher rates of car crashes. I think a lot of the data and some of what's cited from here has really come from states that have legalized much earlier than other states. And so certainly Colorado and Washington have collected a lot of data on marijuana use and how it impacts their population. And so some of these studies are cited from them. Next slide, please. So now wanting to focus more on marijuana use during pregnancy. So this was the second population that I had highlighted in the NISDA data. So marijuana use more than doubled among pregnant women from 3.4% or 78,000 in 2015 to 7.1% or 161,000 in 2017. Again, going back to the NISDA data slide I showed earlier. A growing number of states are legalizing marijuana for medicinal or recreational purposes, and it is being used by pregnant women. And we're seeing increases in marijuana use among pregnant women over time. And in some cases, what we've heard anecdotally from certain studies is that some women have been told that marijuana use can actually be something that's helpful to take during pregnancy. So the legalization of marijuana really gives this false impression that marijuana is safe and the perceptions of harm are associated with it are decreasing. And so again, going back to the normalization of marijuana use, and that is so legalized in many states, that has really impacted and increased the use. Next slide. So social media states that marijuana is an effective and safe treatment for nausea that accompanies pregnancy. However, there's no research that shows that this is a safe practice. Emerging data on marijuana's availability across the placenta and the effects that in affecting the development of the fetus raises concerns about pregnancy outcome. And there have been some specific studies that I'll talk about in a minute that talk about some of the risks associated with marijuana use during pregnancy. Next slide. So marijuana use during pregnancy may be associated with the following: fetal growth restriction, preterm birth, stillbirth, and neonatal intensive care unit admissions. And so these studies, again, going back to the earlier comment, really document a lot of the risks that are associated with marijuana use during pregnancy. Next slide. Both the American College of Obstetrics and Gynecologists and the American Academy of Pediatrics recommend that women refrain from using marijuana while pregnant, and all women should be screened for marijuana use at intake to an OB/GYN care and counseled about potential adverse health consequences of marijuana during pregnancy. Next slide. So the key policy issues. So I think one of the main concerns is that science really lags behind policy, and policymakers are looking for data to guide their decisions. So as we've seen, going back to the map of the U.S., all this legalization that has occurred very rapidly every year, there seems to be more and more states that are legalizing. There really isn't the data to back up a lot of these policy decisions. So I think that's an important consideration for all of us in the prevention field to be thinking about. Also, substance use is affected by availability, cost, and perception of harm. So as marijuana is more available and less expensive, people might use it more. We've seen some of these examples in tobacco, for example, which we'll be hearing more about. And also the perceptions of harm from marijuana use are decreasing across all age groups. So that certainly is very important as well, that if we are not showing the risk factors associated with marijuana use and people don't see and hear that, then they potentially would be more likely to use marijuana. Next slide. So SAMHSA's response. So what are we doing given the concerns that we're seeing with increased marijuana use, and again, particularly among these populations that I highlighted, adolescents and women of childbearing age. So SAMHSA has recently put out several evidence-based practice guidebooks through our Evidence-Based Practice Resource Center that address marijuana use, and 3 are listed here. The first one, which was released late last year, Preventing Marijuana Use Among Women of Childbearing Age, also Preventing Substance Use, including marijuana among 18 to 25-year-olds. And then just recently, earlier this month, actually, SAMHSA just released a guidebook focused on vaping. Vaping framed very broadly because you can vape many different products, but marijuana is one of the sections of that guidebook. So we are certainly putting out information for a lot of individuals, our providers, and folks in the community to talk about the importance of prevention and evidence-based practices to support that. We've also launched the SAMHSA.gov marijuana website, and so this includes a page of resources related to marijuana prevention and treatment. Also, the Substance Abuse Prevention Technology Transfer Centers has a whole section that is focused on prevention of marijuana and other substance use, and you'll be hearing more about that later from Scott. Also, the Center for Substance Abuse Prevention has funded state and community-based grants that address marijuana prevention. So Partnerships for Success, which many of you may be aware of, there have been some flexibilities provided with those funding. So states can address substances that are important to their communities, and one of those substances could certainly be marijuana. SAMHSA has also worked with the Surgeon General to disseminate a marijuana advisory that was released late last year. So those are some of the activities that we are doing to respond, and certainly individuals, all of you, are really important in terms of putting those messages out. And so hopefully you find the resources that SAMHSA puts out useful, and we certainly welcome your feedback on any of them as well. Next slide. Next slide.
Sorry, apparently it
Okay,
seems to
I think that was my last slide, actually. So I think we're good. Okay. So I think we have time for a few questions before we go on to the next presenter, if there are any, or we can do them at the end of all presentations as well.
Well, thank you, Dr. Clark. While questions are queuing up, I wonder if you could take a moment to share a little bit more information about SAMHSA's latest resource, which you just mentioned briefly, the vaping guide. What kind of information is in there and how can people access it?
Sure, thanks for the question. So the vaping guidebook that I had referenced, it's available on SAMHSA's Evidence-Based Practice Resource Center website, or you could also just go into the SAMHSA homepage or Google vaping evidence-based practice in SAMHSA, and it should pop up. About a year and a half ago, SAMHSA developed a new product called the Evidence-Based Practice Guidebooks, and these are intended to be very short guides that really outline a particular issue or problem in substance use, and then examples of evidence-based practices that practitioners or people in the community could implement in order to address them. So we've put out guidebooks on stimulant use disorders, which was just released about a month ago. We also have done guidebooks on medication-assisted treatment for individuals in criminal justice settings, for example. The vaping one that I mentioned highlights a lot of the evidence-based practices that we know right now. I think one of the challenges with vaping is that it is a fairly new area, and so a lot of the evidence-based information that we have is somewhat limited. So this guidebook will probably be a resource that will evolve over time, which is true for a lot of our guidebooks. As more data and research become available, we want to update our resources. But there are a handful of practices in there that you may find useful.
Great, thank you so much. We have another question that has come in. What is being done for individuals who have zero or low literacy skills? No written material will be useful.
Yeah, that's a great question. So SAMHSA has done some resources that are more audio. These guidebooks, however, are not presented that way, but that is something we could certainly look into. So that's a very good comment. We would probably need to think about a way to, have an audio piece that's more condensed than what is currently in the guidebook. So that's a good comment. Thank you.
And I believe that there's also resources on SAMHSA's YouTube channel, right? That would be available for people who don't have literacy skills.
Yes, that's a good point. Yep, and through LinkedIn as well, you can find those. Yep.
Great. I think this is the all of the questions that we have so far. Oh, I'm sorry. I have one more. Are there individual literature that can be used on social media? So are there SAMHSA resources that could be shared on people's social media sites?
Yeah. So the information that's on the website is for the public, so that could be used. It has all of our SAMHSA logos. So if you wanted to link it to your resources, that would be fine. They could not be changed, obviously, with SAMHSA's name on it, but they're available to the public. So you could certainly link them to your sites as well.
Great. And I think in addition to YouTube, you can also follow SAMHSA on Facebook and Twitter, where resources and information are shared, and those could be easily retweeted and reposted. Great. I think that is all of our questions now. So I'm sorry, one more coming in. I'm sorry, Dr. Listel, who'll be coming up next. One more question for Dr. Clark. Since science lags behind policy, how do we talk with legislators who are making policy decisions based on people saying it worked for them?
Yeah, so I think it's important to highlight what we do know currently about the adverse effects of marijuana use. And again, there are several studies that I referenced in the presentation, and there certainly are many other resources as well, some of these guidebooks that I had mentioned. And so I think it's always helpful to back up your argument with data. And so I think showing that information is helpful. There certainly are things that we don't know, and we don't know what we don't know. So I think it's also very helpful to state that it's premature to be making decisions when we have a lot more to learn as well. So those might be some talking points that could be helpful.
Thank you so much. And those are all of the questions that we've received so far. So I think we can pass on to Dr. Listel.
Great, thank you so much.
Well, good morning from Wisconsin. Gonna try to get these slides up and running. Can you guys see them?
Looks good.
All right, great. So I'm Dr. Krista Lisdahl. I'm a professor of psychology at the University of Wisconsin-Milwaukee. And today I'm going to be talking about an overview of the effects of really chronic, repeated cannabis use in adolescents and young adults, and focusing in on how it affects cognition and brain structure and function. And then I'm going to take a few minutes to give an overview of the Adolescent Brain Cognitive Development, or ABCD study, focusing in on the substance use methods and some really early substance use patterns in the ABCD kids. So I just want to give a nod to the fact that cannabis is a very complex plant and therefore complex drug. There are over 100 cannabinoids that have been measured. And today, when I'm talking about the neurocognitive effects, I'm really focusing in on high THC content product that people are using recreationally. So THC is the cannabinoid that's really related to that subjective high and altered state of functioning that people really take for recreational purposes. Oops, did I lose my slides? Okay, hopefully not. Cannabidiol, you guys have probably heard of, I would think at this point. You might see it at your gas station or at your salon. CBD products is another cannabinoid that's related to actually having some antipsychotic, anticonvulsant, and neuroprotective properties, at least in animal models. But it's notable that CBD content is actually very low in recreational cannabis, and it's actually been going down as THC potency has been going up, as Tom mentioned. I'll talk about this later, but product that contains higher levels of CBD and lower levels of THC may result in fewer cognitive or psychopathology symptoms in cannabis users. So how does THC affect the brain? How do you get high? Well, THC acts as a partial agonist at the CB1 receptors in the brain. And here is an example CB1 receptor. The natural endocannabinoid system in the brain that THC interacts with is related to emotional regulation, reward processing, executive functioning, and memory. And we have evidence that CB1 binding in the brain increases from adolescence into adulthood. And over here, we have some PET scans showing the areas that really increase in that sensitivity or binding through adolescence into adulthood. A couple regions that stand out to me that I want to point out is the prefrontal cortex and the parietal cortex, which continue to develop and mature into young adulthood and are indeed the last regions to mature, as well as some of these subcortical regions like the amygdala and the hippocampus related to emotional processing and memory. So that natural endocannabinoid system is thought to play an important role in neurodevelopment, relating to strengthening connections between neurons and pruning weaker connections as the gray matter prunes back during adolescence. And that neurodevelopment during adolescence into young adulthood creates a more efficient, well-tuned brain into adulthood. Now, what happens if you use cannabis chronically during adolescence into young adulthood? Well, we have, again, some PET imaging evidence that the CB1 binding reduces in cannabis users, although we see some recovery of function over a month of abstinence. And again, the areas that were most robustly related to this reduced CB1 binding is the prefrontal cortex and parietal cortex again, as well as some areas in the brain like the anterior cingulate that's related to emotion processing and executive functioning, in the hippocampus, which is related to verbal memory. We also have some animal studies demonstrating that chronic THC exposure to adolescent animals is related to several kind of structural as well as functional changes in the brain. Just like the human studies, we do see a downregulation of those CB1 receptors, especially in females. We see actually a change in the structure of the dendrites, including things like reduced length and complexity in areas like the hippocampus and the prefrontal cortex. And this is related to how those regions connect or communicate. We see changes in glutamate signaling in synaptic plasticity that may disrupt this pruning process that's supposed to happen during adolescence. Of concern, we do see some epigenetic changes, meaning downregulation or upregulation of certain genes related to opioid addiction and heroin seeking that lasts into adulthood, again, in the animals. We also see changes in microglia in the cerebellum, which is related to reduced motor function. And if we chronically give THC in the adolescent animals, we see functional deficits that are both qualitatively and quantitatively different than if we administer it to animals. And this was related to this abnormal glutamate and GABA signaling. So that just gives you that kind of neuroscience underpinning for how something like cannabis or THC administration might disrupt the naturally occurring endocannabinoid system during this important period of adolescence. So going into review studies on the matter, and actually I just have to say I'm part of a lot of the studies that fed into these review or meta-analyses, and I can talk about some of the individual studies, but I really wanted to give you a larger overview of the state of the literature. So these are recent review studies. The first one looked at a series of longitudinal studies looking at the effects of cannabis in adolescents and young adults. And the overarching conclusion was that cannabis leads to neuropsychological decline. The associations were modest and dose dependent, so meaning the more people use, the worse the outcomes. And this was particularly true for verbal memory and complex attention. The next one highlighted here is a meta-analysis, specifically looking at functional connectivity, so how the brains were kind of communicating different regions in the brain during cognitive tasks. Marijuana users demonstrated reduced bold or brain activity in the anterior cingulate, that area that you've heard a few times now. And this was related to abnormal co-activation with frontal, parietal, and limbic areas during cognitive control tasks. They also had abnormal activation in important regions like the dorsolateral prefrontal cortex during attention tasks, and actually had increased brain activation to reward in the striatum during these reward fMRI tasks. The next one specifically looked at abstinent adolescent marijuana users who hadn't used marijuana at least 25 days. And they found that these adolescent users actually had increased activation in central, executive, and default mode network areas compared to non-users, suggesting that basically their brain was working harder to achieve the same thing. These are some meta-analyses looking at the effects of cannabis on cognitive functions. And if we look here at the major conclusions, the first one concluded that there was a small negative effect for both global and most neurocognitive domains in cannabis users compared to non-users. And the second one concluded that there was a significant effect for learning, set shifting, processing speed, cognitive control or inhibition, working memory, and attention. But this was mostly true for the studies that only had a length of abstinence of about 72 hours. Once the studies that had longer lengths of abstinence had smaller effect sizes. This is just a graph of that. In the gray area here, these are the significantly reduced effect sizes. So the biggest ones being in learning, especially verbal learning, executive functioning, processing speed, and working memory and attention. Things like language, visual spatial skills, and gross motor skills seem to be spared. Tom brought up this Meyer study, and I just want to highlight it a little bit further. So this is a prospective longitudinal study starting at ages about 7 into age 38. They looked at both cannabis use disorder as well as regular cannabis use, which would mean that people used at least weekly for the past year. And they found that both cannabis use disorder and regular marijuana use was associated with reduced IQ, working memory, verbal memory, sustained attention, processing speed, which you've heard these cognitive effects with the meta-analyses as well. It was also related, interestingly, to the informant saying that the participants who used marijuana had worse everyday problems with attention and memory, so they really saw some functional impairment. These results held after controlling for a past 24-hour use, comorbid alcohol and nicotine use, diagnosis of schizophrenia, and years of education. And these graphs highlight that the adolescent onset users had the most significant differences between their childhood IQ and their adult IQ. And the most robust difference was in people who both used at childhood and adolescence and during adulthood. So you see here they have the most robust drop in their IQ from childhood to adulthood. Over here we have non-users across the whole time, and you see a little bit of a positive trajectory in their IQ. Of concern to a lot of people was that the folks that used during adolescence but not adulthood still did have a significant decrease in their IQ compared to childhood, begging the question on whether or not there's a sensitive period here and whether or not if people stop using, do they fully recover back to their childhood trajectory. Here I want to highlight a few prospective longitudinal studies that are smaller but have some interesting findings. The first one, and all of these kind of started at ages between 11 and 15 or so before any onset of significant use, and then followed folks into ages 19 to early 20s. The first one found that early frequent marijuana use was associated with reduced verbal IQ, reward processing, executive functioning, as well as lower graduation rates, controlling for premorbid functioning. And these lower graduation rates did help explain some of the lower verbal IQ, but not the other cognitive deficits. The second one was specifically in girls, and they found attention problems in the marijuana users after controlling for other drug use, family factors, conduct problems, as well as peer substance use, which is kind of related to the general environment that they're in. Some good news here was that they found some evidence for recovery of functioning if they maintained abstinence for a year. These last two are interesting because they're not looking at kind of colder cognition outcomes, but more affective processing or social neuroscience outcomes. This one by Mary Heitzig and colleagues found that marijuana users had increased negative emotionality and decreased resilience over time. And this was related to abnormal affective processing in areas of the brain like the prefrontal cortex and limbic regions. A second study found that marijuana use is associated with decline in social reciprocity skills between ages 15 and 18, controlling for all sorts of factors like maternal, childhood factors, and premorbid social cognition. So these studies highlight that some of these other factors like resiliency and negative emotionality are important outcomes to look at. So this is the trajectory of non-users, whereas over time during adolescence from ages about 15 to 19, resiliency is increasing in the non-users, but significantly going down in the marijuana users, especially perhaps during these middle school years. And negative emotionality is going up, even though premorbidly they were a tiny bit different, but not significantly. And these factors were related in a dose-dependent way to their marijuana exposure. There is some evidence that questions these findings, and primarily related to whether or not some of these findings are related to a shared genetic component. So these two studies looked at, again, marijuana users versus controls over time from ages about 9, 12 to 18 to 20. Both of them did report that marijuana use was associated with lower IQ, as well as other areas of cognitive functioning, such as working memory. However, when they specifically looked at twins that were discordant for marijuana use, they didn't see a difference in IQ, although the first study did still find differences in working memory. But there's been some criticism to these studies to date because, for one thing, IQ is not the best outcome. It's more important to look at like executive functioning, working memory, processing speed. The other thing is that the sample size for discordant twins were quite small, so they might have lacked some power. And the third issue is that the way marijuana use was measured was pretty crude. Both of them used categorical measurement. The second one, you were a marijuana user if you had basically ever used 30 times in your whole lifetime. So there wasn't very fine-grained measurement. The last few studies I want to highlight are looking at adolescents who were marijuana users and following them over time to see if the interim marijuana use was linked with ongoing neurocognitive problems. And in this first one, the marijuana users continued to show poor working memory, planning, verbal memory. They did find that earlier onset of marijuana use was associated with poor verbal learning and planning. This was also linked with poor white matter integrity in prefrontal and parietal regions, and there were dose-dependent relationships between cannabis and poor white matter quality. The second one, again, found similar neurocognitive deficits highlighted here. Again, earlier onset was related to even worse neurocognitive outcomes. And they also linked it with some structural abnormalities in cortical thickness, especially in frontal and parietal regions. And again, these were dose-dependent relationships. This last one is interesting because they looked specifically at functional connectivity in the brain over time, and they found abnormalities in the way brain regions were communicating, such as the anterior cingulate, which I've brought up several times now, the orbitofrontal cortex, and the dorsolateral prefrontal cortex. And again, they found dose-dependent relationships with lower IQ and slower processing speed. So there are some factors that we haven't researched very well that we need to know more about, such as the potency and content of cannabis. When I first started talking, I admitted that cannabis is a pretty complicated drug, and there is some evidence that potency matters a great deal. Oops, sorry. So over here, we're finding that evidence that more potent cannabis, for example, is related to increased risk to having a psychotic episode. Over here is an older study showing that if people smoked cannabis that had higher cannabidiol content, meaning also lower THC, they had fewer cognitive deficits. So here is the higher THC, low cannabidiol, and they did show verbal memory deficits, but the people who smoked higher cannabidiol product didn't. So this is an area that needs more research, especially as people are using more and more potent THC products, such as vaping, THC concentrate, or oil. The other thing I want to point out is most of these studies only had an abstinence period of about 24 to 72 hours. And so these are all the areas of cognitive function that we see impaired at that point. The issue with that is THC, someone isn't high, they're not acutely high on it, but it might still be in the system, or someone might be in withdrawal. Some studies have looked at a week of abstinence, and most of the acute withdrawal is complete at that point, but only a few studies really looked at 3-4 weeks of abstinence when THC is totally out of the system. And less is known about the recovery of function in some of these neuroimaging areas because there's very few longitudinal studies that have looked at it. But I want to note that there is some recovery in cognition. I see that verbal memory, simple working attention, or working memory and processing speed can improve with 2 to 3 weeks of abstinence, even though we do still see subtle differences in the neuroimaging. So there's a little bit of a question whether that's true recovery or just successful compensation, but it does give us hope that if we get people to stop using, they do have some rebound in their cognitive functioning. Some other areas that I didn't talk about that are important to consider is that cannabis is related to other areas of harm, such as just basically youth not reaching their full potential. So we see regular cannabis users have reduced GPA, educational achievement, reduced income and employment, and life and relationship satisfaction. And loved ones do report everyday problems in cannabis users' attention and memory. Cannabis use can lead to cannabis use disorder, as well as other health factors, stress and affect, and increased risk for psychopathology, such as psychotic episodes, depression, suicide, and mania. So in summary, so far, repeated recent cannabis exposure during adolescence and young adulthood has been linked with modest abnormalities in neurocognition. Frequent potent THC patterns appear to be most detrimental. Adolescents and earlier onset appear to be the most vulnerable compared to young adults or adults. And in fact, findings from adolescents shouldn't necessarily be generalized to like older adults or full-on adults. And it's important to delay the onset of cannabis use in young people. I also want to note that vulnerable groups are typically excluded from this study. So there's some folks we don't know a lot about, such as really heavy users who can't maintain even a couple days of abstinence. Those with really heavy comorbid substance use, psychiatric or medical comorbidities are typically excluded. So we might underestimate these findings in really vulnerable groups. On the flip side, it's important to note the clinical significance of that. So cannabis users are statistically significantly different than non-users, but the differences are modest. They tend to be 10 to 15% difference, like maybe a difference between an A and a B or a B and a C. There's some evidence that the findings may be due to premorbid differences, such as shared genetic risk or environmental risk that are linked with substance use initiation. So we really do need large-scale prospective longitudinal studies like the ABCD study. And again, I want to highlight this hopeful evidence that some of these things recover even pretty rapidly within the first 2 to 3 weeks. So we want to encourage abstinence. So the last few minutes, I just want to give a highlight of the Adolescent Brain Cognitive Development Study, which is a large-scale, kind of big data collaborative study across the country where we have enrolled 11,875 youth aged 9 to 10 nationwide, and we're going to be following them for 10 years, and we do have funding through 2027. The study utilized a school-based, epidemiologically informed recruitment strategy, and it also is twin-informed with a nationally diverse sample, and we're going to be looking at several factors that might influence brain, cognitive, emotional, and health development. And importantly, we're assessing all of these things prior to the onset of any sort of significant substance use. There are several research objectives of this large, big science project, but I'm going to highlight the latter two. Where we're trying to understand the interrelated relationships between mental health and substance use over time, and study how the use of different substances, including caffeine, nicotine, alcohol, cannabis, and really all the substance categories, how they affect developmental outcomes and vice versa. This is a collaborative project across 21 sites with good regional representation throughout the United States, as well as coordinating and data center in San Diego. Adolescents and their parents come in once a year, and every 2 years we have a really intensive neuroimaging protocol, as well as cognitive testing, bioassay samples. And then in the interim, we do some kind of mobile technology or telephone interviews every 3 to 6 months. The sample is diverse. At baseline, they're between the ages of 9 and 10. They're split by sex or gender. There's representation across most major ethnic and racial groups, so about 52% Caucasian, 15% African American, and about 20% Latinx or Hispanic. About 18% of the sample are twins or triplets, as well as some siblings, and then the rest are singletons, so we can look at this shared genetic components. There's representation across, parental education and household income categories. And focusing in on the substance use assessment, we are on a yearly basis collecting detailed characterization of their substance use patterns. At the younger ages, when they first use, we kind of measure that first use. So if they've sipped alcohol or puffed a nicotine electronic delivery device or puffed some cannabis, we're measuring that incidence and getting some details about it. We're using the timeline followback to get really patterned use of all substances, including measuring things like co-use days and length of abstinence. We're looking at substance use attitudes like expectancies, perceived harm of substances, availability, intention to use, subjective response during their first few uses for alcohol, cannabis, and nicotine, motives to use. We also look at things like peer use, sibling use, household density of use, secondhand exposure, family history of substance use, parent rules about substance use, parental monitoring, things like that. Consequences of substance use, as well as substance use diagnosis and withdrawal symptoms. We also collect biological samples, including saliva, urine, breath, and hair, to look at more objective measures of substance use. So what are these 9 and 10-year-olds doing? Well, the good news is that the vast majority have not tried any substances, so 74%. That doesn't include caffeine. About 75% of them have used caffeine at baseline. More boys than girls are sipping alcohol, but overall about 23% have some alcohol sipping, although the vast majority of those people who have sipped alcohol have only sipped like once or twice, and then they stopped using. So they did not go on to finish the full alcohol drink. Less than 1% have puffed a cigarette, pipe, ends, or hookah. About 48 of the kids both sipped alcohol and puffed some nicotine at baseline out of those nearly 12,000 kids. 12 kids have tried cannabis at baseline. Only 5 of them had more than 1 puff. And the majority who had tried cannabis had also sipped alcohol. But the bottom line is that they're very substance naive. For those folks who have tried cannabis, those 12 kids, on average, they had about 7.5 puffs. The range was 1 to 40. But notably, the vast majority, 10 of those 12 kids, stopped after their first puff. They were about 8.5 years old when they first tried it. The majority smoked it, although one smoked very potent cannabis, one had an edible, and one tried a tincture. And youth reported getting the cannabis from primarily family members and then a couple kids from friends. They were kind of split in how buzzed or high they felt. About 50% really didn't feel anything from their puff or two, whereas 25% felt very high. About half the youth were offered the cannabis. 4 of them intentionally took it and 2 accidentally took it. So over time with the ABCD study, we're going to be trying to determine to what extent these neurocognitive abnormalities are due to premorbid or shared genetic risk factors versus actual cannabis exposure. We're going to be looking at the impact of product type, like whether or not they're smoking or vaping or using edibles, potency, like if people are smoking concentrates versus flower, content. We're going to try and measure things like self-reported THC content versus cannabidiol, and also look at hair samples to see if we can differentiate THC versus cannabidiol. And we're also going to look at drug co-use. We're going to do things like look at the impact of circulating endocannabinoid levels on development and what repeated cannabis use does to those endogenous endocannabinoid levels. We're hoping to identify at-risk and resilient subgroups, understand more about the role of environment, policy, family, and cultural factors on risk for substance use as well as neurocognitive outcomes, and look at this interplay between cannabis and psychiatric disorders and long-term outcomes. Finally, we want to determine whether sustained abstinence results in returning to their original neurocognitive trajectory. So, for example, if someone used cannabis regularly from ages 16 and 17 and they stopped 18, 19, and 20, do they get back on their original kind of brain and cognitive trajectory that we were measuring before age 16? Just want to acknowledge my wonderful lab who do so much work every day. Really appreciate them deeply. The NIDA, NIAAA, and several other funding sources for this research, as well as our ABCD partners and collaborators. And thank you all very much.
Thank you so much. That was really wonderful. We have a couple of questions that have come up before, and we have about 4 minutes before we're going to go on our break. So one of the questions is, the common belief is that marijuana use helps depression and anxiety. Is there any research on CBD's impact on these issues?
So CBD specifically, there are some very small, non-blinded clinical trials looking at very acute effects of CBD on, acute mood. In other words, there is some preliminary evidence that it could be helpful to either reduce depressive symptoms or anxiety symptoms, but right now the state of evidence is too insufficient to make any real conclusions. We really need larger scale, double-blind, placebo-controlled clinical trials that are, going into 8 to 12 weeks, not just one single dose reducing someone's symptoms for one day.
Thank you. Another participant writes about the ABCD study. She's curious on how you are building trust to get accurate results on use.
Yeah, that's a great question. So we have to make sure that information collected from youth is confidential. And so we make sure that it's really clear to the youth and to parents that all information is private and confidential, unless there's a really acute medical emergency. We also, of course, provide treatment and mental health resources to all parents and youth in the study, and have a lot of communications with parents about, if they have questions about substance use issues, we give them more global information about how to identify a potential substance use issue and how to get, treatment resources, but we don't share any information about their particular child. The other thing is that we really invest a lot of time and energy into making it a very positive experience for the kids. They come in at least once a year. We develop relationships over time. And there's a lot of research showing that if you create, a safe, inclusive space and provide confidentiality, that you get very accurate reporting. But with that said, we also do collect toxicology. Saliva samples give us a window of about 24 to 48 hours of past use. Hair gives us between 1 and 3 months of drug exposure. So, we're trying to balance getting as accurate of information as possible, but also having some objective measures of use. And there is evidence that some of the kids are underreporting based on the toxicology.
Great, thank you so much. Another question: what is the average THC potency in medical marijuana?
That's a good question. I actually can't necessarily say for medical marijuana. I would say that for recreational marijuana, it's more towards 18%, which is quite high. Some of the studies have found more like 12%, but they're really lagging. So if you go into like Colorado or Washington or California, where there's a legal market, you get closer to 18% as the average, with a range of like 12 to 24%. So potency has gotten quite high. The medical marijuana question is important, and I want to say that there could be subgroups such as like adults who have pain, for example, who are really pretty cannabis naive and are taking a very low dose of cannabis, let's say a 5 milligram edible pill or much lower THC content smoked cannabis, where you might even see some improvement in cognitive function because you've treated their pain. So I think we need to be careful to not generalize across studies. So if my studies are only on adolescents and young adults, and they're recreational users using very high potency product, and I see neurocognitive deficits, we can't generalize that to, say, Stacy Gruber's medical marijuana study, where she has on average 50-year-olds who are using low doses of high CBD, to THC content medical marijuana and once a day at a very small dose, and they actually see a somewhat improvement in their cognitive function. So it's a complicated topic. It definitely matters what the potency is, what the content is. Is it a CBD versus THC product? And it seems to really matter how old you are.
Great. Thank you so much. We do have a number of questions that are pouring in for you, but I am afraid that it's time for our break. So we will all be taking a 15-minute break. If you look at the top of your screen, you'll see that there is a tab called Wellness Breaks. Please feel free to click on that. You'll have options of different wellness activities that you can be engaging in during our 15-minute break. Thank you so much, Dr. Clark. Thank you so much, Dr. Lissel. We will be starting again promptly at 11:45 with Dr. Ralph Hingson. So thank you so much, and please come back in 15 minutes. We'll start again at 11:45. Thank you. And we will try to address the questions later on in the session. Thanks so much. Welcome back, everyone. Thank you for joining us for the second portion of this presentation. Before we start with our next speaker, I do want to remind people that you can access all of the PowerPoints by scrolling to the bottom of the screen. You'll see links for everyone's PowerPoint presentations. It will ask you for a password, and that password is MYTI 2020. So please feel free to go and use those slides. All right, next up, we will be hearing from Dr. Ralph Hingson. He's the director of the Division of Epidemiology and Prevention Research at the National Institute on Alcohol Abuse and Alcoholism. And he will be talking to us about alcohol policies that reduce underage and alcohol drinking, lessons for marijuana. Dr. Hingson.
Thank you, Ingrid. Before I begin, I want to thank the two previous speakers for their superb and highly informative talks. They were really great, and I learned a lot from them, listening to them. So as it was mentioned, as Ingrid mentioned, I'm going to be talking about alcohol policies to reduce underage and adult drinking, and whether or not there are any lessons that we can learn from those that apply to marijuana. Next slide, please. Alcohol misuse contributes to nearly 90,000 deaths every year. It's the third leading cause of preventable death in the United States. It tends to affect, there are more of these deaths that are injury deaths than are chronic disease deaths. And so they tend to affect younger people. And the injury deaths actually account for twice the number of preventable years of life lost as the chronic disease deaths. CDC, which provided these death data, also estimates that alcohol misuse costs the United States about $249 billion a year. That's the equivalent of $750 per person per year. About 9% of those costs stem directly from underage drinking. Most of the costs result from binge drinking, and more than half of the costs that are borne by this drinking are paid for by state, local, and federal government and by people other than the drinkers. So that there are important secondhand effects of alcohol misuse. I think that when we think about public health achievements in our lifetime, certainly reductions in tobacco use is one of them. And a key factor in that was when people recognize that smokers don't just harm themselves, they harm other people. There are two problem areas of alcohol prevention where we've made considerable progress. One is reducing underage drinking, which I'm going to focus on a lot in this talk, and the other is reducing alcohol-related traffic deaths. Those have been cut in half per population since the early 1980s. Underage drinking, as we will see, has declined even more than being cut in half. In the last 15 years, there's been renewed interest in preventing underage drinking. In 2004, after convening a series of conferences on underage drinking, the National Academy of Sciences published a report called Reducing Underage Drinking, a Collective Responsibility. I wrote the chapter about the magnitude of underage drinking problems for that report, dedicated it to a young man named Terry Sterling, who was a freshman at Old Dominion University in Virginia. And during fraternity hazing ritual, he was asked to drink until he dropped. Well, he did drink until he passed out. And what the fraternity brothers did was they placed him face down on a bench. And when they came to see how he was doing a few hours later, they found he wasn't breathing. So what they did, unfortunately, was that it took a half an hour to clean up all the liquor bottles and beer bottles in the fraternity house before they called 911. And by the time 911 arrived, Terry had died. Another of the people who were pledging for that fraternity also ended up having to go to the emergency department for a resuscitation, but fortunately he survived. Episodes like that, and there were a lot of them, generated federal action. The Surgeon General released a call to action to prevent and reduce underage drinking in 2007. In 2006, Congress passed what's called the STOP Act, a very important piece of legislation to reduce underage drinking. First, they created what's called the Interagency Coordinating Committee at the federal government level. There are 15 different agencies. Next slide, you can see them listed on this. You see the slide with the Surgeon General and the STOP Act, and then the next slide, please, lists the agencies that were in the Interagency Coordinating Committee. We meet monthly. The Substance Abuse and Mental Health Services Administration coordinates these meetings. We meet monthly to look at the magnitude of the problem, whether or not we're making progress, and what strategies seem to be most effective in reducing the problem. In addition, next slide, please, the STOP Act mandated that there be annual reports prepared and sent to Congress that describe the federal efforts to reduce underage drinking, as well as what each state in the United States is doing to reduce underage drinking. Each of the 50 states was encouraged by the STOP Act to develop strategic plans with measurable goals to reduce underage drinking and to form interagency task forces at the state level, just like we have at the federal level. Many states, I think at least nearly 40 states have done so. Supplemental grants were also provided by SAMHSA to communities to enhance community efforts to reduce substance use, to add reducing underage drinking to their agenda. There have been several national media campaigns that SAMHSA has conducted about underage drinking. They've convened 10,000 town hall meetings to discuss underage drinking and its magnitude, its consequences, and how to prevent it. Collectively, the different federal agencies spend about $160 million a year to prevent and reduce underage drinking. I can think of no area of alcohol prevention where there's the coordinated effort at the federal, state, and local level and work between government and private citizens that's comparable to the efforts to prevent underage drinking. Next slide. A key in reducing underage drinking has been raising the legal drinking age to 21, but there are many other laws that states have passed to reduce underage drinking and related problems, and this is just a listing of some of the laws. Next slide. This next slide talks about many of the things that the states are doing, the strategic plans and the interagency coordinating committees, their efforts to enforce underage drinking laws like compliance checks, stops and shops, shoulder taps, and party patrols. Next slide. So the question is, why has there been so much focus on underage drinking? Well, there are a number of reasons. Back when the Surgeon General's report came out, or the call to action in 2007, there were nearly 5,000 underage drinking deaths attributable to, or underage deaths attributable to alcohol misuse. It's fortunately down to 4,200 by 2017. In 2007, there were 1,500 alcohol-related traffic deaths among people under age 21. Fortunately, that's also been brought down to a little under 1,000 by 2017. Underage drinking is also associated with poor academic performance, potential cognitive deficits, unplanned and unprotected sex after drinking, physical and sexual assaults, higher tobacco use and drug use, suicide, poisoning and overdose deaths, and secondhand effects of alcohol to others. And this is very important. For example, half of the people who die in traffic crashes involving drinking drivers under the age of 21 are people other than the drinking driver. There are a lot of innocent victims, and I'll come back to that because I think that's an important area that needs to be looked at with regard to marijuana. The Youth Risk Behavior Survey conducted by CDC annually indicates that there are over 1 million high school students who consume 5 or more drinks at least 6 times a month. The NISDA study that SAMHSA does, which covers 12 to 21-year-olds, or through 20-year-olds, says that maybe there's 2 million who do that in that age group. If you if you include high school students and others, and those who drink that heavily, that frequently, 5 or more drinks, by the way, on an occasion, is enough to get both a male and female up to a level of blood alcohol level of 0.08, which is a legal level of intoxication for adults throughout the entire country. So these young people are drinking frequently to intoxication, and as a whole, those who drink that heavily compared to other young people are much more likely to engage in behaviors that pose a risk for their behavior, for their health, and risk for other people's health, such as riding with drinking drivers, driving after drinking, so they're more likely to be in motor vehicle crashes, not wearing safety belts, so that when they're in those crashes, they're more likely to be injured or killed. They're more likely to carry weapons, to be bullied, to be injured in fights, to be engaged in risky sexual behavior with multiple partners. to have unprotected sex, to use other drugs, to inject drugs, and to be injured in suicide attempts. And of course, suicides, unfortunately, are going up among young people in the United States. Next slide. The next survey indicates that they're also more likely to drink at school. About a third of these frequent heavy drinkers report that they drink at school, and about a quarter of them smoke marijuana at school, on school property. So it doesn't take magnetic resonance imaging studies to figure out that if they're drinking and smoking dope at school, that they're more likely to be getting mostly D's and F's on their report card, and that's in fact exactly the case. Next slide. We published a study last year where we looked at the Youth Risk Behavior Survey and found that 7% of high school students binge at 2 times the age-specific threshold. 9% binge at less than the threshold, and 14% drank but didn't cross the binge threshold of 5 or more drinks for a male or 4 or more drinks in a 2-hour period. Those who drink at twice the binge threshold, that's 8 or more drinks for a woman or 10 or more drinks for a man, they achieve blood alcohol levels of 0.10, which is twice the binge threshold. And if you look at behaviors, next slide, that those young people engage in, those people who are engaging at twice the binge threshold, they're much more likely, 3 to 4 times more likely, to be using other drugs, to be smoking cigarettes, to be in motor vehicle crashes, and nearly 3 times more likely to be getting mostly D's and F's at school. So this heightens the risk of underage drinking. Next slide, please. We have data that indicate, just like marijuana use affects cognition and memory and executive function and judgment of young people, so too does alcohol. And while the early studies were cross-sectional, and we didn't know which came first, the cognitive deficits or the heavy drinking, we now have several prospective studies that indicate that actually it's a little bit of both. That cognitive deficits precede heavy drinking, and the heavy drinking contributes to cognitive deficit. And as in the last talk, we learned that even after a month of supervised abstinence, that next 2 slides, please, that some of these cognitive deficits persist. This is a study by Windward, who found that these cognitive deficits persisted even after a month of supervised abstinence, and they affect adolescent daily experience and can influence academic performance. Next slide, please. We also know that, as with marijuana, the earlier young people start to drink, the more likely they are to develop alcohol dependence at some point in their life. Those who start drinking at age 14 or younger, over 40% at some point in their life will develop alcohol dependence. Next slide, please. This is true not only in general population studies, but it's been found, as with marijuana, in twin studies where the twins are discordant on whether or not the age that they started to drink. The earlier you start to drink, the more likely you are to develop dependence. Next slide. Not only are people more likely to develop dependence, they're more likely to develop dependence at an early age and develop chronic relapsing dependence, characterized by more episodes, longer episodes, and meeting more of the diagnostic criteria. I dedicated the article that I published on this phenomenon to a young man named Brian Paul McKelvey. I met his mother at a CANCA conference. She told me about how her son had developed a very serious alcohol problem, so serious that by age 16, they had entered him into alcohol treatment. He was doing better. He was in recovery, by the way, when unfortunately at age 19, he was struck and killed by a repeat offender drinking driver. What that tells me is that while treatment is effective and helpful, we can't treat our way out of this. We have to also think about the environment that surrounds the people who engage in this heavy drinking. Next slide. We've also found that early onset of drinking is related to other substance use problems in adolescents, risky sexual behavior, car crashes after drinking, physical fights after drinking, and unintentional injuries after drinking. I like to dedicate my articles to people to put a face on the issue. It's not just numbers and relationships that we're talking about. So I dedicated this to a young man named Michael Timothy Wilder. I was telling his mother about why I like to dedicate my research articles to people to put a face on the issue, and I noticed that there were tears welling up in her eyes. She'd lost her son, Michael, 18 years earlier when he was struck and killed by a drinking driver. I thought I was being sensitive. I don't think I fully appreciated the enduring pain that alcohol misuse can cause many families. Next slide, please. Early onset of drinking is also associated with suicide, violent and predatory behavior and predatory violence, dating violence, criminal behavior, prescription drug misuse, unplanned and unprotected sex after drinking, and adults injuring themselves and other people after drinking. Why are these findings important? They're important because injuries are the leading cause of death among young people ages 1 through 44 in the United States. And alcohol is the leading contributor. So what we're talking about is the leading contributor to the leading cause of death among young people in the United States. Now, the good news is that the literature on how to prevent underage drinking has expanded rapidly in recent years. I have posted in the next slide an article that I wrote about that. We've learned that we can intervene on several different levels to reduce underage drinking, at the individual level, at the family level, at the school level, through web-based interventions, through environmental policies, and comprehensive community interventions. And I'm going to focus on the environmental policies. That's what I was asked to talk about. Next slide, please. There are numerous environmental policy interventions that have been shown to reduce drinking and driving, which is, as I said, been cut in half in the United States since the early 1980s. Criminal per se laws, administrative license revocation, where the police can seize at the scene the license of a driver who refuses an alcohol breath test, who fails to test, mandatory assessment and treatment of people who are convicted of driving under the influence, primary safety belt laws, ignition interlock laws, which we're trying to get across the country right now, lower legal alcohol limits for convicted offenders, 0.08 for adult offenders. Utah has now gone down to 0.05. Use-lose laws, where young people who use alcohol have their license suspended. Graduated licensing laws, and enhanced enforcement using publicized sobriety checkpoints. There are also other environmental policies that reduce drinking and in turn reduce the consequences, such as raising the minimum drinking age, reducing alcohol outlet density, and increasing the price of alcohol. These are summarized in the chapter on prevention in the Surgeon General's report to Congress, Facing Addiction in America. It's the Surgeon General's report on alcohol, drugs, and health. By the way, there have been over 30 reports on tobacco by the Surgeon General, and that's helped to produce the sea change that we've seen in tobacco use. But this is only the first that dealt with both alcohol and drugs. Next slide, we can see that this is a trend in binge drinking by high school students and college and college age individuals, and we can see that it's declined dramatically. The steepest declines being for high school seniors, where it's been more than cut in half. Next slide, please. This looks at alcohol-related traffic fatalities in the 16 to 20-year-old age group, and that's been reduced by 80% since the early 1980s. There's no age group that's had as great a reduction as the 16 to 20-year-old age group. Next slide, please. Clearly, raising the drinking age to 21 played a pivotal role here. CDC has reviewed 49 studies published in scientific literature that shows that when the drinking ages were decreased, alcohol-related traffic deaths among young people went up, but when they were increased, they went down about 16%. Next slide, please. Jim Fell did a 20-year analysis of the fatality analysis reporting system. This is traffic deaths in the United States, controlled for numerous confounding variables. Next slide, please. And he found that raising the drinking age was associated with about a 16% decline, as did the CDC study, and found that other laws also produced declines. Use-lose laws, zero-tolerance laws, lower legal blood alcohol limits, administrative license revocation, and seatbelt laws. Next slide. This slide is an article by Bill DeYoung, who I worked with at Boston University before I came to NIAAA. And the title of the article, I think, says it all. Case closed. Research evidence on a positive public health impact of the age 21 minimum legal drinking age in the United States. The National Highway Traffic Safety Administration, next slide, estimates that raising the drinking age has prevented over 30,000 deaths in the United States. I think actually that's an underestimate. Next slide. It's an underestimate because it didn't look at the other harms that alcohol misuse among young people creates, and it didn't look at the long-term carryover benefits of legal drinking age into adult life. We now have studies that have looked at national surveys that have found that people who grew up in states where they could drink legally before 21 as adults are more likely to experience alcohol use disorders and drug use disorders. Next slide. And they're more likely as adults to die from liver disease and oral cancer. Next slide. It's not just raising the drinking age to 21. Jim Fell did another study where he looked at 20 underage drinking laws and found that 9 of them produced independent significant reductions in alcohol-related traffic deaths. Next slide, please. This slide lists those 9 laws, and collectively, according to his analysis, they prevent over 1,100 alcohol-related traffic deaths each year among young people. Not all states have all of those laws, and he estimates that if all states adopted all of those laws, that there would be another 200 or more deaths that would be prevented. Next slide, please. Well, the question becomes, is passing laws enough? We've been talking about policy during this talk. There was a seminal study that was done in Washington, D.C., the nation's capital, where the Insurance Institute for Highway Safety gave 2 young people under the age of 21 money and asked them to go around to 100 liquor outlets in Washington, D.C., in our nation's capital, and try to purchase alcohol. And what they found was that 98 times out of 100, they were able to buy alcohol, even though it was illegal to sell alcohol to them. So, next slide. That indicates that it's not just enough to pass laws. There's a whole process of change after a drinking age increase. There has to be education about why we have the laws, about what the laws are, and how they're going to be enforced. And we need that to change attitudes about the perceived dangers of consumption, and to create legal deterrence, which in turn we hope will reduce drinking and driving and alcohol-related traffic deaths. This process best takes place at the community level. Next slide, please. And that's where CATCA comes in. You play a critical role, an absolutely critical role in preventing underage and adult drinking in the United States, and have done so quite successfully. There have been numerous multi-component community interventions that have been found to reduce drinking and related problems among adolescents and adults. Next slide. I don't have time to go through each of those individual successful multi-component community programs, but they share common features. They coordinate multiple departments of city government. They have clear, measurable goals and objectives and strategic plans. They combine education and law enforcement. They include screening and early intervention and increased treatment. They use data to plan and evaluate. They involve private citizens. They're inclusive, and they include youth. All of those features are contribute to successful programs. Let me give just one example. Next slide, please. This is a program that I evaluated called the Fighting Back Program, funded by the Robert Wood Johnson Foundation. And that was the first program to both use environmental policy to limit alcohol availability and to expand treatment for substance use. And what we found, next slide, was in the 5 communities that adopted those laws compared to 5 control communities in each of the same states, over a 10-year period that the program was in place compared to 10 years prior, there was over a 20% reduction in alcohol-related traffic deaths. So a highly successful program. I dedicated my research article on that to a young boy, Courtney Birch, who at 3 years old was approaching an ice cream truck when a drunk driver struck him and killed him. So in conclusion, the research indicates that we can reduce alcohol, underage drinking, college age, and adult drinking through interventions that focus on individuals, families, schools, environmental changes, and community enforcement of those environmental changes to heighten their effects. As we learned in the first presentation, next slide, we live in a country where marijuana is becoming increasingly available through medical marijuana laws and through legalization of recreational marijuana use. The first speakers provided a very solid overview of what we've learned about the harms that marijuana use causes the individual marijuana users. But we have other questions that we need to study as well. What are the secondhand effects of marijuana use? We know, for example, that, as I said, 40% of the people who die in crashes involving drinking drivers are people other than the drinking driver. We don't know that about marijuana-related crashes because we don't have adequate testing for marijuana in our fatality analysis reporting system. We need to also learn more about the combined use of alcohol and marijuana and what the impact of that is on cognitive development and on unintentional injuries and intentional injuries. So what are the implications of these policies for marijuana? Well, I think we should ask whether an interagency federal working group like what we have for underage drinking would help, should be developed for marijuana, and whether or not that would help coordinate our efforts. We need to find out what laws will be effective. Will repealing recreational marijuana use or other medical marijuana use be effective? Would laws like drinking and driving laws, and per se laws, legal limits, administrative license revocation, use-lose laws, mandatory treatment also reduce marijuana-related problems? And finally, can our multi-component community programs be adapted to include not only reducing alcohol use, but also reducing marijuana use and combined alcohol and marijuana use? And there's some emerging evidence that these community programs can do so. I would encourage you to look at the articles by Comroe and Livingston last 2 years in the American Journal of Public Health, where they found that community programs focused on alcohol also reduced marijuana use and reduced related problems. Thank you very much for your attention.
Thank you so much, Dr. Hinkson. That was very interesting and I think gave us all a lot to think about as people are thinking about how to make policies and what are the considerations as they're facing new changes in the legality of marijuana. So this takes us to our second break. We're going to take another 15-minute break. Please, again, feel free to visit, to scroll down below where you can have access to all of the PowerPoint presentations that have been done today. Please feel free to scroll to the top of your page where you will see a tab on wellness breaks, where you can engage in a wellness exercise or activity during this next 15 minutes. And again, we will be starting promptly at 12:30, where we'll be hearing from Scott Gagnon, who is going to be sharing a lot of very useful and important resources for you as you are addressing marijuana use in your communities. Thank you so much, and we will be back with you again at 12:30 sharp. Thanks so much. Hi, Scott. We'll be starting you off in about 5 minutes. I can see you and your slides look great.
Great. Standing by.
I can hear you as well, so all looking good.
Always good.
Welcome back, everyone. I hope you had a nice break. We will be ending our session with Mr. Scott Gagnon, who is the director of the New England Prevention Technology Transfer Center. He will be sharing information on marijuana prevention training and technical assistance resources. Thank you so much, Scott.
Thank you. So good morning or good afternoon to my friends on the East Coast. I'm glad to join you all for the kind of cleanup position here for our panel today. And definitely want to thank SAMHSA for inviting me to be a part of this great panel. Really enjoyed the previous presentations, and kind of my role here is, hearing a lot of the great data and science and information you heard before, and actually saw a couple of the questions in the chat box about how to, translate complex science into presentations and how to use this. That's really our role at the PTTCs, the Prevention Technology Transfer Centers. This is where we can come in to help you with training and technical assistance to figure out some of these things, like how do you get all this great information, this great science into your work to enact change in your communities. So what I'm going to do is kind of give you a little brief overview of the PTTC model. There is a full session tomorrow morning, actually, is going to go deeper into the PTTC model, so I encourage you to take a look at that. But just for some background, make sure we're kind of all on the same page of what the PTTC model is. And then talk a little bit about some tools and resources we've developed around marijuana prevention, training, and education, and then some regional examples of offerings across the country. So I want to start with sort of the mission and purpose of the Prevention Technology Transfer Centers, and they're really twofold. One is to improve the implementation and delivery of effective substance use prevention interventions, so getting that prevention research and science into practice. And then the way we do that is through the provision of training and technical assistance services to the field. And there's some important pieces to that. One is we want to make sure that our trainings and services are tailored to meet the needs of the field. We want to make sure that they're based in prevention science and use evidence-based and promising practices, and then also to leverage expertise and resources that are available through alliances formed within and across the regions of the country and within our PTTC network and other federal, state, and local partners. So the way the PTTC network is set up is there's 10 regional prevention technology transfer centers, and the map here shows you how the country is divided up into the HHS regions. So we have one PTTC per region, and on this map you can see where each of those are based. So for example, here at New England PTTC, we're based in at AdCare Educational Institute of Maine. There are also two national specialty PTTCs, one that is the National Latino and Hispanic PTTC. The other is the National American Indian and Alaskan Native PTTC. So those provide focused training and technical assistance for those populations. Now, when it comes to the types of training and TA services we provide through the PTTCs, there's really three different levels. And you'll see when we get a couple slides, this forms a nice pyramid. So the first level is what we call universal technical assistance. So this is really one-way technical assistance and communication. So there are things like mass mailings, publication of information such as newsletters, untargeted presentations. So these may be webinars that are wide open, anyone can register to participate in. And then also things like website and social media materials. So with respect to marijuana, a couple of examples I can provide is one is the PTTC network nationally recently hosted a webinar on vaping and THC, and it might be something you actually participated and viewed. So that's kind of a universal level where it wasn't really a closed audience. It's really open to anyone who had interest in learning about vaping and THC prevention. Another example is, email blasts, whether it's advertising an upcoming training or a resource that was developed by one of the individual PTTCs. The next layer is what we call targeted technical assistance. So those can be online courses, webinar series, focused knowledge sharing communities of practice, short-term training. So more often than not, it's a one-time offering that's a little bit more focused to a specific population. It may be a specific prevention organization, it may be for a specific state, but there's some subset of the prevention field, either within our region or within the country, that we're focusing this technical assistance for. So again, some examples specific to marijuana are, many of the PTTCs engage in training, these kind of targeted trainings around marijuana prevention strategies. So maybe around a particular type of approach, and it's usually tailored to local data and local needs. So that's another key difference, is that it really is weaving in what's going on at the ground level in states and communities to tailor the delivery of the service. Another example is here in New England, we have a marijuana policy and prevention course that we've provided as a live webinar. We also have it available now as a recorded webinar used for sort of on-demand viewing. Another one, which I'm going to go into more detail in a bit, is our national PTTC marijuana prevention toolkit, and I'll talk more about that in a bit. The bottom layer is the intensive technical assistance, and that is more ongoing TA that's really probably geared towards a specific organization or group, where it's not just a one-time training. It may start off a training and then be followed by a series of technical assistance calls or meetings. One example here from New England is we very recently wrapped up a Project Echo session on vaping. And if you're familiar with the Project Echo model, it's a series of sessions that build upon one another, where we take a number of groups through different case scenarios on how to kind of develop and implement and get feedback on implementing vaping prevention approaches. We've also had some ongoing prevention trainings that we've been doing in Maine and Vermont in our region. Again, they're kind of building on each other, and there's some follow-up that happens after these webinars. So there you can see the pyramid all together. The other important piece of our model is that, and this will be familiar if you're with the strategic prevention framework, is that it's wrapped in an approach that's culturally and linguistically appropriate. So I kind of hit upon this already, but there's definitely a wide range of different services and products that come from the PTTCs that, again, hit all those three levels. So newsletters, in-person trainings, live and recorded webinars, which of course with COVID which is a lot of what we're doing right now. Self-paced online courses, tailored intensive technical assistance, podcasts. Some of our PTTCs are doing podcasts. And then different types of tools, whether it's literature reviews, implementation guides, infographics, white papers, and a lot of that's driven by the requests that we get from the field. So I want to talk a little bit more about the toolkit I referenced before. So one of the ways the PTTC network is organized, so we have the 10 regional centers, but another way that we're organized is we have these national areas of focus across individual regional centers, and so you can see them listed here. And so what we do with this is we have work groups for each of these 7 areas, and each of those work groups consist of multiple PTTCs. So we're getting perspective from across the country to develop prevention, training, and technical assistance services on these topics. So of interest for this session, I want to talk a little bit more about what we've developed within the marijuana risk work group. So the marijuana risk working group exists to develop training and technical assistance tools, products, and service related specifically to marijuana risk education and prevention that can be deployed across the country. So as I mentioned earlier, one of the beauties of the PTTC network is it does provide that regional approach to developing training in TA. At the same time, we also, we want to be mindful of being efficient with our work. So there may be instances where it's helpful for centers to come together to develop a framework for a particular training tool or type of technical assistance, which then can be regionalized using data and local conditions. So this is an example. I'm going to talk an example of how we've developed that. So here you can see the membership of our work groups. So you can see we have centers represented across the country. I serve as the chair of the work group. Michelle Fry-Spray from the Northwest ETTC is our co-chair, and then you can see our other members. So we're in year 2 currently of the sort of first 5-year cycle of the PTTC network. In year 1, our work group created a marijuana prevention toolkit. And it consists of 4 different tools, which I'm going to walk you through. 2 of them are slide banks. One is a marijuana myth and fact sheet, and one is a cannabis glossary. So I'm going to give you a little bit more details of each of these components. So first of all, the purpose of this toolkit, our goal of this was to provide research and vetted tools that prevention practitioners can feel confident using in their marijuana prevention work in their states and communities. So we know there's a lot of questions, and we've seen some of those in the chat box already. Our mission and our goal is to provide something that you can feel confident in, that's gone through a process, has been vetted by multiple experts, subject matter experts, that you can use right away in your prevention work in your states and communities. So you can find this on our website. So if you go to pttcnetwork.org, you'll see a tab, a projects tab, and when you go to the focus areas, you'll see that graphic I showed you before. Each of the work groups there's a link. When you go to the marijuana risk link, it will take you right to a page that has the components of this toolkit listed. And there's a link to download all of these components. So the first one I'm going to talk about is a fact and myth sheet. So they have 7 sort of common myths or misunderstandings related to marijuana science that we pulled together. And so what we did is we identified those 7 myths, and we did the research, pulled the research together to kind of provide the factual information related to those. And then it's also cited. So if you want to get more information about any particular study related to the facts, you'll have a resource that you can go to. So the goal is to provide the workforce sort of the science and knowledge to be able to engage and answer some of these questions that may come up in their community presentations. So some ideas of how you could use this toolkit is you could use them as a handout for tabling events, which of course is something we can't do right now. So when we can, it can be great subject matter for social media posts, content during things such as Drug Facts Week, National Prevention Week, and then other kind of coalition activities you may be engaged in. Now, one bit of feedback we have heard is not everyone is a big fan of sort of the fact versus myth framing, and we certainly understand that. But sort of our answer to that is the science is still solid. So if you want to reframe that in a different way through how you post on social media, that's certainly fine. But know that the science is still there to help you answer those questions that may come up. The other tool that we developed is a cannabis glossary, and the main goal of this is when you are, often in community conversations about marijuana and cannabis, there's different sort of sectors represented, different parties, and there may be terminology that's used. For example, if you have folks from the industry involved in a town meeting or a town hall meeting, they may use terminology that you may not be as familiar with. So this is just to kind of help you with that, some of the slang terms, plant anatomy, those kind of things. You can have some good literacy when it comes to these conversations. So the last 2 components are the slide banks. And so these are 2 researched and cited slide banks for prevention professionals to be able to use in your education and prevention work. So one is on the varied forms, potency, and health effects of today's cannabis. The other slide bank goes into cannabis and the impacts on the adolescent brain. So each of these slides bank does include presenter notes to guide you on using the slides. Includes references and links to all the source material. And there's also some different components you can use, such as videos, that can maybe help sort of be another way to kind of get the information through, which depending on your audience you may want to use. So both of these slide banks are set up in those ways. You can use them together or you can use them separately depending on how much time you have. And they are slide banks, so even within one slide bank, you may not have enough time to get through the whole content. You can take a few slides out if you need to. The only thing we ask is you do not alter any of the contents of any of the slides. Again, if you need to take out slides for time, that's certainly fine. We just ask you don't change any of the contents of any of the slides. Now, if you need any further assistance utilizing this toolkit, that is where you're going to want to reach out to your regional PTTC for assistance. So that's one of the things that they can help you with, is how to, if you have any further questions on how to use the toolkit or any feedback, you definitely want to get in touch with your regional PTTC. I'll have my contact information at the end as well, so you could also reach out to me on that. So now I want to walk you through some examples of some regional PTTCs and some of the training and technical assistance they're doing around marijuana prevention. So I'll start with my PTTC in New England, a couple of examples of programs that we're providing. So we have actually two trainings that we've developed that we've been offering in our region. One is called Prevention Skills in the Era of State Legal Cannabis. So in our region, we have 3 states that have some form of legal adult use marijuana. So we put together a training that's really looking at how to use data and research on marijuana to develop those prevention approaches while the policy context is changing in their communities. The second training focuses more on the policy aspect, the evolution of marijuana policies and where prevention fits in. And this one is really focused on improving marijuana policy literacy and talking about the importance of that literacy in informing the crafting of your prevention approaches. So in this one, we're really going much deeper into sort of the anatomy of marijuana policy, sort of the stages of marijuana policy as it evolves in states, and how prevention sort of needs to keep on top of that, but also how at each step of the way prevention has a role in providing education in the community. So it's just a couple of examples of some content that we include in that training. One is we talk about, again, the different stages in policy development. So often what you see in a state is it starts with some kind of legalization initiative. If that passes, then there's an implementation law that will go through the legislature, and there's different aspects that are important for prevention providers to understand about that. And then if that passes, it goes into rule and regulation making. And that's yet another layer that those of us in prevention need to understand in how it affects our work. And why that is so critical and important for our field is that when it comes to marijuana policies and rules and regulations, there is what is in those rules and regulations and laws, but then there's what isn't in there. And both of those have an impact on the risk factors that we care about and that are working to address. And if we don't understand that, if we're not on top of that, it's going to be much harder for us to craft prevention approaches that address how those policies will affect our risk factors. And I provided some examples of things you'll find in policy that we really need to be aware of. Things like advertising, rules around labeling and packaging, buffer zones, possession limits. There's just so much that's in policy that we need to be on top of. And that's one of the things we hope to accomplish with this training, is to raise awareness and competency in understanding those and how it links to your work in prevention. When we talk about where does policy fit into the SPIF, well, it really fits everywhere, but it's definitely an important part of your assessment process, because if you don't have that context in your assessment process, you're going to be missing a key factor in the community. Another example of training that we've done in New England is we had a training from the director of our Northern New England Poison Center, looking at some of the science around edibles and some of the confusing information that's out there, particularly around driving. And this is actually a recorded webinar now, which if you have my slides, if you go to this link, you can actually view this recorded webinar. And that's one of the beauties of the PTTC network, is that we may do targeted webinars and trainings in our region, but often we're recording these and posting these. And then if you're in another region, you can still access and view these. The Southeast PTTC recently did a webinar on prevention in a changing landscape, and kind of similar to, I think, what we did in New England, looking specifically at the policy changes that are emerging in that region, with a focus on Florida and things around their medical marijuana law. And again, this is something that's been recorded and that you can view. Our National Hispanic and Latino PTTC has done a webinar focused on sort of the reality of legal marijuana in Hispanic Latino youth, myths, truths, and consequences. So it looks at the science, a lot of the science you've already seen today, but really drills down into, in particular, how does the changing laws and landscape affect Hispanic and Latino communities, and how can prevention professionals and communities and coalitions really address that in their programming. The Mountain Plains PTTC has developed a 3-part series of webinars looking at different aspects of marijuana prevention. The first one was planning and implementation. The second one was looking at more of the policy piece, which actually I was the presenter for that. And they have an upcoming one on cannabis pharmacology that they're in the process of scheduling. So if you are in the Mountain Plains region, you want to be keeping on top of what's on if you're not following that PTTC, you definitely want to do that, so you'll be aware of that next webinar. They also developed an infographic that looks, again, at some state-specific data that could be very helpful, again, if you're in that region doing prevention work. So there's many more. So that's really just a highlight of what's going on across the network. All of the PTTCs are engaged in supporting the field, supporting you with training and technical assistance around marijuana prevention. So definitely, if you haven't linked with your regional PTTC and you haven't looked at their website, highly encourage you to do that to see what they have available. So pttcnetwork.org is where you want to go to check that out. And that's really the plug I'll kind of end with is, if you haven't connected with your PTTC, definitely do that. Of course, we do more than just marijuana. We address alcohol. We address all different types of substances. We address implementing different types of evidence-based strategies, risk factors. I mean, anything you can think about. So definitely connect with us if you need help. I mean, especially after today's webinar, we have lots of questions. What can I do with the science? How do we implement this? Is there a particular program out there, evidence-based program, that we could use for this risk factor? Reach out to us so we can help you figure that out. I'm going to end with my contact information. I want to make sure we have enough time for questions for me and for our entire panel. So definitely reach out to me at my email address if you have any follow-up questions about anything I've talked about. We're the PTTC network, and my particular PTTC is on Twitter, so follow us there. It's a great place to get updates about upcoming trainings and services. But I think many, if not all, the other PTTCs are on there. So if you do a search, you'll find out. Most of us are also on Facebook and other social media outlets, so definitely check those out. But with that, I will wrap up. And any questions that may come up?
Thank you so much. We do have some questions in the queue for you. And Dr. Lisdahl, if you could appear again, that would be great. We have a couple questions for you. So Scott, one of these questions came in, and this could be for either of you, but thought it would be particularly good for you. Any tips for us on how to translate complex science into a way that our community members can understand?
Do you want to go first?
Sure. So what I usually do, and it depends a little bit on what community, but if I'm talking to parents, I tell them that the bottom line is we've done this research to try and understand how to really optimize adolescent health. And adolescence is really the last period where the final connections of the brain are really optimizing and becoming more efficient and adult-like. And so we have this golden opportunity to really set adolescents on a path of healthiness. Like, it's that golden gateway to the most healthy option, into adulthood. And that repeated drug use, including alcohol, nicotine, and cannabis, which are the most popular ones, disrupt that. Okay. In the case of marijuana, it seems to be the difference between like a B and a C. It really reduces people's performance. And the riskiest patterns are people using when they're young, so 17 and younger, and people who are using often and really kind of intense THC products. So it depends how much they're using and depends how old they are. But our biggest purpose is to prevent, as long as possible, someone using a substance like that regularly, so that they have reduced risks for, cognitive problems. It reduces their risk for having emotional problems like anxiety and depression. And it really just gets them on the optimal health pathway. And then if people want to dig in further, so I try really hard not to overstate findings. I don't. I think it's really problematic when people really overstate and make it seem like, people are going to be severely cognitively impaired and have no opportunities in life. Because frankly, people will come back and say, well, that's BS because I know Tom and I know, Cindy and they used and they're fine. So you really have to speak the truth and what the evidence is saying. And, myself as a parent, I'm trying to make sure that my kid has the most opportunities in life. And it's pretty clear to me that regular marijuana use reduces those opportunities.
Terrific. Scott, anything else you'd like to add?
I think the tip that I would provide is, I think one important piece is to link to focus. If you have a good sense of where your audience is in terms of speaking to, what their concerns are, is to try to hone in on what the primary concerns are. I think sometimes when we have a lot of evidence that we want to provide, there can be a inclination to provide it all at once. And so I think that's the piece, is how can we target, so we know academics, is an important piece. So then we want to focus on some of the cognitive pieces that we're talking about. So I think as much as we can pair the particular chunk of science to the particular concern, and because I think one benefit of that is it might help you get a foot in the door with more maybe skeptical audiences if you can really link what your audience is concerned about versus throwing everything in the kitchen sink at them, because A, it's overwhelming, but B, again, I think it's kind of getting the foot in the door. And I think of the example of alcohol, sort of like the Parents Who Host Lose the Most campaign. Part of that is, there may be parents that are less concerned about certain aspects of how alcohol affects people, but they may be concerned with some of the legal ramifications and insurance ramifications. So it's kind of getting a foot in the door, but it provides an opportunity once they are in the door to expand to some of those other areas. So that's kind of a tip that I would provide, is try to link it to what you see in the data as the top concerns in your community.
Terrific. Thank you so much. We only have 3 more minutes and lots of questions, so we will unfortunately not be able to get to all of them. This is a quick one for you, Scott. In the slide banks, would it be okay to insert our own local data?
Yeah, that's a question we've had. Definitely, I would say if you want to, so if you have a few slides of local data, definitely, I think that's fair game to drop that in for sure. And I certainly would encourage that. Because certainly if you're using, at best we have national data, so you're going to definitely want to include that. So that's definitely fine, not a problem at all.
Terrific. And another one specifically for you, have you done any webinars about marijuana and tribal lands?
So I mentioned there is a national PTTC for American Indian, Alaska Native. And so I believe, our region in particular hasn't, but I believe that center has. So I would encourage folks to check out their website. I know they've done some work around marijuana prevention. In fact, they're part of our work group, our national work group. So I would encourage you to check out their website. And if there's something there you don't see, send them a request and see what they can do for you.
Terrific. And I think we'll only be able to get one last question in. And this is, we are looking for examples of compliance checks from marijuana retailers. Do you know of any compliance programs currently being conducted?
I'm not aware of specific ones myself. But that, again, it could be another place where your regional PTTC could help. I'm not sure what region the questioner is from, but I would encourage you to reach out to them to see. They may have knowledge of that.
Okay, great. And I think we can squeeze in one final question. I think you've already mentioned it. Where another final plug about where people can access the materials you were referencing.
So pttcnetwork.org, and I think someone put in the chat box, but you'll see a drop-down box to find your regional PTTC. So go there, but there's also a search bar at the website. So if you're looking for a particular type of resource, put it in there, and you'll get a listing of different resources. So you'll find it one way or another. And if you don't, contact. Sound like a broken record. Contact your PTTC, and they'll help you.
Wonderful. And so we are at the hour. Thank you so much. I want to thank Dr. Tom Clark, Dr. Krista Lisdall, Dr. Ralph Henson, and of course, Mr. Scott Gagnon for all of your wonderful information that you've been able to provide to everyone. I want to thank all of our participants today. It's been wonderful hearing you through the chats and the questions, and we hope you have a wonderful remainder of the CADCA conference. Thank you so much. Have a great day.